What is up, you guys? So today is April 3rd, and I am actually doing a WebEx call with one of my professors from last semester. His name is Professor Delclos. He has his MPH, his PhD in public health, and I thought it'd be helpful to ask him some questions that a lot of people have about COVID-19, especially since we're all kind of going through it right now. There's some stuff that I personally want to learn myself, so I thought it'd be useful for my time too, since I do have a lot of downtime other than school, to do one of these little webinars and potentially inform everyone else too about what the real hard facts are. From the answers that I did get, a lot of the things that he was mentioning was the fact that there is so many things that are unknown. It's important to follow through and to just keep an eye out on reliable sources of information, such as your local health departments, CDC, of course. There's a lot of stuff that's circulating media as well, and one of the biggest things that we have to focus on, rather than pointing the finger at everyone, is to make sure that it won't happen again. So that's kind of where the silver lining is at the moment. There's definitely going to be new findings every single day. New things are emerging, new information is emerging, so there's never going to be one set answer at this point in time. But because we're so limited on resources, it's a fairly new viral infection, then there's so many questions up in the air. But I hope this helps clarify some of that information for you guys. I know it helped me a lot, and just to gain kind of a perspective of someone who's in the field and kind of going about the entire situation. So I hope you guys enjoy the video. I'm sorry if the audio is not the greatest. I am using the audio from my laptop. If I could implement subtitles while he's talking, so you guys can kind of like read along to actually see what he's saying, and then maybe I'll also display the question at the top of the screen, so you'll know what question is being asked and what answers are being provided for that question. So that's currently what I'm kind of up to right now while I'm in quarantine, and that's pretty much it. Stay safe and wash your hands. Okay, first and foremost, before we get this video started, I have no idea as to why I left my hairbrush a hanger, and then also why the back of my head is looking a hot mess. It isn't a Chelsea video if I don't incorporate a meme, so there you guys have it. Hope you guys enjoy the rest of the video, and yeah.
Hi, listen, I had to join by phone. I have to drive somewhere.
Oh, no, you're good.
That okay?
That's completely fine. Thank you so much for agreeing to meet with me,
Sure.
even for like a shorter period of time. One thing that I actually discussed, or that was pointed out yesterday, because I was actually attending a webinar with Joseph McCormick and Susan Fisher yesterday. They had like an hour-long webinar yesterday, and they were discussing how there's a possibility that there's evidence to prove that COVID-19 is airborne. And I just didn't know what your thoughts were in regards to that.
Well, we know it can be airborne in certain circumstances. Certainly if you're performing aerosol-generating procedures in the hospital, like intubation, extubation, or giving nebulizer treatments. For example, that's why the American Academy of Pediatrics, for example, for asthma patients, children especially, where we give nebulized medications, bronchodilators a lot. They're encouraging everybody to try alternate methods of delivery so that you don't generate the aerosol.
Okay.
What else can I tell you? There has been some talk about, at least in some instances, it might be airborne. That's a really important issue because it may provide justification for a more widespread use of things like masks now by the general population, right?
Right.
Because up until now we've been saying, and I do think it was a good advice, that people not wear masks in part to preserve them for the people that are dealing more directly, you know, with patients with COVID, because they were in short supply. you know, one of the things that's characterized COVID is every day brings a new twist or a new finding that makes us have to constantly tweak our recommendations, and there is nothing wrong with that, because what we're doing is we're adapting to the science.
Right.
Okay? So the airborne thing is relatively new. I haven't read through all of it yet. I don't know what the CDC's position is, but that's certainly what I'm going to follow when they make up their minds. You know, there's a lot of stuff going on, and you know, as long as it's based on science and there's a rational, common sense justification for making changes to existing recommendations, I think that's great. I mean, that's what we want. We want to let the science drive the recommendations.
The main source of information that we have in regards to that is the fact that it's passed through droplets when people sneeze or when people cough. Would you say that through just like inhalation of a person with COVID-19, it's possible to transmit the disease by just simply inhaling the same breath as a person with COVID-19 who didn't sneeze or cough or anything, or let go of any droplets like that?
Well, that's the concern. I think, you know, I didn't listen to Joe's talk. I actually had it earmarked to listen to that, and I am going to listen to it because it's probably a lot more up to date than what I have. I've just been following sort of the news. I'm spending so much time triaging people and evaluating exposures that it's hard to, you know, find a piece of time to set aside for an hour-long seminar.
Right.
So what I can tell you is, I mean, it would depend on the circumstances, right? You know, what distance are we talking about? I mean, what breadth? Are we in an enclosed environment? Are we outdoors? Certainly, the greater the proximity, the greater the likelihood. You know, if you're many, many feet apart, that's probably, certainly in an outdoor setting, that's probably unlikely.
Right.
So I think a lot of things need to be taken into account, but I don't think we need to blow off airborne transmission given these new findings. That's different from saying there's enough evidence to now make very widespread recommendations to the community. Even though some of these recommendations have already been made, for example, in hospitals. You know, you look at hospitals like Memorial Hermann, and everybody is wearing a mask there. It doesn't matter who they are.
Right.
Everybody's wearing a mask for the last week. I mean, that's the way, you know, epidemic outbreak investigations and management of epidemics work. We tweak it as the evidence emerges every day when it makes sense to tweak it.
Right.
I need to personally learn a little bit more about it. I'm going to listen to whether I need to see the evidence, and I'm also going to pay attention to what CDC is recommending in response to that.
So would you recommend?
But you know, let me add one thing. But I can also tell you that at least in the hospitals, and that's what I'm responsible for as a member of a very large team here at UTHealth, you know, wearing masks is working.
Okay.
It is working. Because once you start talking about aerosol transmission, airborne transmission, then the level of protection offered by a surgical mask is no longer likely to be sufficient. You may need to go back to N95s, and then remember that N95s, which provide a higher level of protection, were in short supply. So you got to balance all that stuff.
Right. Gotcha. Is it possible to be infected with COVID-19 and be asymptomatic for the entire duration of the disease? So I know that
we don't know that. Yeah. No, go ahead. Sorry.
Because I know that there's been many studies. One study in particular that they pointed out yesterday during the webinar was one that occurred, I believe, in Iceland, where they tested everyone, and 50% of the individuals who had COVID-19 actually came back were asymptomatic, so they didn't experience any symptoms. I don't know if it's possible for it to be asymptomatic for the entire duration, for those full 14 days, and it just still kind of like leave your system, or is it something where you're going to get sick? You might just not get sick at the beginning of it, you know?
Right. So I certainly think it's possible to be asymptomatic through the entire period. I certainly think it's possible. We are not equipped in the U.S. to do a similar study at Iceland because we are still short on testing availability, and therefore you've got to ration your tests to those who most need it, either the sickest patients in the hospitals that are suspicious for COVID, or the healthcare workers taking care of them. As tests become more widely available, then that's going to be an important question to answer, right? It's a denominator question in epidemiology. We also have to be careful with the word asymptomatic, right? So that has to have a definition. Asymptomatic may not necessarily mean no symptoms at all. It should mean that, right? But it may not necessarily be defined as that. It may simply mean not having any of the symptoms that we are considering are important in COVID, such as cough and shortness of breath.
Right.
But you can have people that might have, for example, a very mild runny nose, and that might not get counted as a symptom necessarily. And these people that we call asymptomatic, it may be transient, very, very, very mild symptoms that not even the person pays much attention to it, much less would they be screened.
Right.
So, to answer your question, is it likely that somebody can be asymptomatic the entire time, really, really asymptomatic? I mean, you'd have to be very strict in your definition of that, but it's certainly possible.
Mm-hmm.
Once we get the antibody test rolling out, where hopefully some light will be shed on whether there's a certain level of immunity conferred by having had a COVID infection,
right.
We'll know, because if that test becomes widespread, for example, you'll be able to test tons of asymptomatic people if it's widely available.
Right.
And all of a sudden people said, I never had a symptom, you'll find that they're positive, they have antibodies. So that will answer the question.
Right.
We are seeing increases in Texas as a whole. The Houston-Harris County area is, the cases are fewer, and they are increasing a little bit more slowly. I don't know what that means. If that means we're just getting ready to take off. There's certainly been more cases this week than last week, and I anticipate there will be more cases next week than this week.
Right.
The rate of increase is going to be very important.
Gotcha.
And Houston is no exception. So, Dr. Borwinkle and his group were in the Chronicle last week, and they were predicting that in Houston, they originally predicted that in Houston the cases would peak around April 7th, with an end date around May 12th. I then heard recently that those predictions have been pushed farther down the line to a peak later on in April. I don't remember the date right now. It might be around April 23rd, is I think that the date that I seem to remember, and then the end date will be pushed farther, possibly even into June.
Gotcha.
All of these things are based on models, and models have underlying assumption, as you know. Mm-hmm. And so the extent to which those underlying assumptions are correct are going to determine how well the model functions, and they always have to be compared to. Remember that in addition to models, we have real numbers every day, right?
Right.
So looking at those real numbers and how they are, the rate of change day to day or week to week is going to be also for me, it's the most important indicator of what's really happening.
Right.
Now, we got to be careful, because as testing increases, the availability of testing increases, a lot of the numbers are going to go up simply because more testing is being done.
Right.
So it may not be comparable to what we had before.
Right.
So that's got to be factored in, and they're doing that, right? But models are models, and they are useful for planning, but they also need to be tweaked as underlying assumptions are modified.
Mm-hmm. Was there anything specifically for San Antonio? Because I live in San Antonio, so I don't know if you've heard anything in terms of like when the cases should peak, because I know you did mention Houston.
Yeah, I don't know that much. I really should know. I mean, I know when I look at the map that the places that light up are the places that you would expect to light up in Texas. So the Dallas area, Houston area, San Antonio, Austin area. Those are the big ones, right?
Right.
But in terms of cases and all that, I have not in several days now gone back and looked at the specific numbers of San Antonio. What I can tell you is I don't see it hitting the papers as much. So hopefully that means that even though cases are occurring, they are still in a manageable phase. But I really need to look that up, Chelsea. I don't want to. You wanted good data and good information and good answers. so they need to be data-driven, right?
Right.
So I need to look it up. So take that with a grain of salt.
Gotcha.
But right now, I don't see, COVID banging down the doors just yet in San Antonio, but I need to go back and check the numbers.
Do you have like a specific website that you recommend that gives reliable resources? Because I know there's so many things like circulating media right now.
I always say the same things.
CDC, right?
So I rely on, for example, for world numbers and even down to the, now they said they can go down to the county level. The John Hopkins site, I still think is very good.
Okay.
You know which one I'm talking about, right?
Yes, yeah.
John Hopkins site. That's the one that shows up everywhere, where the
that's the one I've been using right now, so.
Basically. So that's one. And then you go down to, even in that map, you can go down to state and even to counties now.
Okay.
But in addition, I would go to your local health department website. And remember that health departments can be city health departments, they can be county health departments. There are some cities and towns that don't have health departments. They probably do have a county health department. So wherever your area you're in, you can go and look at that site and then look at those numbers.
Right.
Sometimes you will find, and it's important to compare, that the numbers don't match. So let's say, for example, you look at Texas on the John Hopkins website, and you look at Texas on the state health department website, and the numbers aren't equal.
Right.
Always, like a good public health student, you should drill down and look at definition. What are they talking about? What counts? In some places, some of these sites, only confirmed cases count. And in others, you have confirmed and presumed. And a presumed case can be, for example, a case that is highly suspicious and may even have a preliminary test that is positive, but it has not been confirmed yet, okay?
Gotcha.
So you always need to look at the underlying definition. So those are my main sources, and then for guidelines on how to act and what to do, I always go to CDC.
Okay.
They don't always get it right, but what they do is clear cut, a consistent message, and it's and it's a good resource.
Right.
Good resource. That's aside from the screw up with the testing that they had at the very beginning.
Right.
In terms of a source for reliable recommendations, that's what I go to, and that's what you're going to hear expressed by the public health authority.
Gotcha. How do you think this is going to affect our orders of social isolation? Do you think it's just going to remain the same as what people are continuing to tell the public in regards to, self-quarantining yourself, staying away from other people? Do you think that's the only changes in terms of social order that they're going to kind of implement in our societies, or?
Yeah, so there's this ongoing balance between mitigating the pandemic and doing what we can as a society to limit the numbers,
right,
to keep the spread under control, and the fact that the economy is tanking and people need to work, right? That's one. You need to balance those things. I am very concerned about. Prematurely stopping social isolation. I really am. We have examples, mainly from Hong Kong, that had that was where things were under very, very good control, and then they loosened up their social isolation and other measures, and all of a sudden the cases came back.
Right.
And so, as tough as it is, and it is incredibly tough. It's not. I mean, it's incredibly hard on families. Not only from the psychological standpoint and all that, but from the income standpoint.
Right.
I mean, I know that they just passed a very large, or the largest stimulus package in U.S. history, but for many families, that's not going to be enough. And, people are still going to be laid off, no matter what they say, or no matter what you call it, furloughed, or it's still,
right.
You go home without a paycheck, and they have to make ends meet. And so they're as desirous going back to work as other folks, but if we do this too prematurely, it's going to, I think it's going to get really bad, worse.
Right. I think so too. Just going off of my personal opinion, I feel that if we go back, or if we rush back into it, we're going to just come right back to the position that we're in right now. Because as you can see, if the cases start to decline, and then we stop like self-isolating, that's going to basically amplify the numbers again. So I totally agree with you on that.
Yeah, that's right. And it is what it is, right?
Right.
We're going to control it. At the same time, this is there's always or we try to look for silver linings, right, on dark clouds. And I think that what this is doing, in terms of people in society in general being very innovative about how they try to manage through this, is going. There's a lot of new stuff that's coming up thanks to this, in terms of new remote working possibilities. Maybe that'll translate into new work arrangements in the future.
Right.
Ways of doing conferences. I do think at the end of the day, the entire world, not just the U.S., is going to have to take a very close look at their health systems, not only from the public health standpoint, but also from the delivery of care standpoint.
Right.
And I don't care if you're a country that has a fragmented healthcare system like ours, where we don't have a national health system, or a country that does have a national health system.
Right.
Every single country is going to have to revisit their health systems and see what went wrong and how can we prevent it in the future. Right. It's not this public versus private thing only. I mean, that is an issue, but everybody's in the main countries that have been hit. If you look at Italy, Spain, Germany, France, the U.S., even China at the very beginning,
right,
and a lot of the other countries, they need to go back and take a look at why did this happen, and why weren't we ready to deal with it? Why couldn't we anticipate it? Remember that I don't want to get political here, but President Obama had set up, as a consequence of the Ebola thing, he had set up an office for pandemics, for global pandemics, and that office was curtailed under the current administration.
Right.
I don't know the degree to which that affected our readiness for this.
Right.
It may have, it may not have, but it certainly needs to be revisited.
Right.
And I think the same with other countries. I mean, countries that have national health services, that's great. You have universal coverage, but people got caught off guard. Everybody needs to revisit what happened and how to prevent it the next time around.
Gotcha. Do you see any long-term consequences for those who have COVID and did recover? Would you say that they'll go back to complete health, or would they still have some underlying conditions that we have to kind of monitor or take precautions for?
Yeah, that's a great question. We know some things and we don't know others. So we know that in the majority of cases, even today, even with limited testing, we know that the majority of cases tend to be relatively mild, but that there are some groups that are more affected than others. We've talked about the elderly, people with underlying chronic conditions. We know that the mortality rate, once you hit the age of 60, starts to decline very quickly, and especially after you're 70 or 80. But still, even the majority of those folks survive. Now, how severely they were affected, I'm a pulmonologist, so I can tell you that, for example, if they had such severe respiratory problems that they wound up on a ventilator in an intensive care unit, and they developed what's called ARDS, which is Adult Respiratory Distress Syndrome, many of those folks are likely to be left with lung scarring for life. Okay. However, when you get beyond that, and you talk about the milder cases, with most viral illnesses in the world, unless there was significant organ damage, you go back to being the way you were. So there's going to be a range of lingering effects, and a lot of it's going to be dependent on the severity of the initial clinical presentation. The second thing is that we need to find out is whether there is any long-lasting immunity that will result as a consequence of having this. For example, if you look at Sweden is taking measures that are a lot more relaxed, if you will, than the social measures that are being taken in other countries, and it's because they have a belief that most people will be mildly affected, and that may actually create a certain level of what we call herd immunity, right?
Right.
We don't know how long the immunity conferred by this virus will last. There's been some discussion about people who have recovered maybe this comes from China, of course, because they have the most extensive experience and the earliest experience, so they're able to look at their numbers.
Right.
There was some early concern that some people who got over their COVID infection were then had a second round.
Oh my.
Suggesting that there might not be immunity, but that was a handful of cases.
Right.
The majority of people so far are, once they get over it, they get over it.
Right.
Now, how long that immunity is going to last is we don't know, right? Is it going to last just a few months? Is it going to be seasonal like it is with the flu, or you have it once and typically you don't have it again that season? But next year you're probably susceptible to the new strain of flu that's running around that year, right? So immunity, that's why we get a flu shot every year.
Right.
Because one isn't enough for a lifelong immunity. Other viral diseases like measles, once you've had it or you've been vaccinated, it's lifelong immunity for the most part.
Right.
So we don't know how this virus is going to behave. It could well confer lifelong immunity, or it might not. It probably will confer some seasonal immunity simply because that's the way viruses act.
Right.
And then we'll see. So there are a lot of unanswered questions that only time will tell. And follow-up studies are going to be very, very important. Just like immunological population-based surveys, serological surveys, and things like that are going to be very important.
Right. Well, thank you so much. I really appreciate your time and fitting me into your busy schedule, because that was really informative. That helped me a lot.